Hello, everyone, and welcome to today's program, the MACRA Final Rule, Highlights and Implications, which is the first webinar of the Life Sciences and Healthcare Spring Series for Norton Rose Fulbright. I am Mark Faccenda, a partner in the Norton Rose Fulbright Washington, D.C. office. Today I am joined by Bernie Duco in our Houston office, and by Joseph Keillor in our St. Louis office. Before we get started, I would like to go over a few housekeeping items. We have applied for 1 hour of CLE credit with the state bars of California, Texas, and New York transitional CLE credit. For attendees outside of these states, we will supply a certificate of attendance which can be used to apply for CLE credit in the applicable bar or other accrediting agency. Today's program will be conducted in a listen-only mode. To ask an online question at any time throughout the program, simply click on the question mark icon located in the toolbar. We will try to answer your question during the session. Everything we say today is opinion. We are not dispensing legal advice, and listening does not establish an attorney-client relationship. This discussion is off the record. You may not quote the speakers without our express written permission. If the press is listening, you may contact us and we may be able to speak on the record. I will note that at the end of the program, if we have time remaining, we'll be happy to entertain additional questions online as well, which you can submit through the question app as I described earlier. So before we begin with the intimate details of the MACRA final rule, I'd like to take a step back and just briefly go over the history of MACRA adoption because the foundations of MACRA and the physician reimbursement methodologies addressed prior to MACRA, I think, are still relevant in that I think you'll find, surprisingly, many of the old legacy payment methodologies are incorporated into MACRA and still would necessarily apply today. So I think that still informs the payment rates and methodologies that are now implemented under MACRA. So before we get into the discussion of the final rule, we'll briefly go over historical payment, which prior to the adoption of the sustainable growth rate formula and ultimately MACRA was initially based and continues to be based in some regard on the resource-based relative value scale, which was a cost-based system which reflected the cost to provide services to patients by physicians. The cost was calculated based on not only the cost to provide the services, but also physical plant and other overhead costs experienced by the physician providing the service. Those ratios were multiplied by various indices to calculate the precise cost to the physician based on their geographic location and the other factors that would make up a location-specific cost to the physician. This cost-based reimbursement scale was paid to the physician minus the 20% coinsurance obligation that the patient was required to pay. So naturally, the cost-based reimbursement system presented the potential for abuse in that cost-based reimbursement really served no check on the overall expenses of the physician to provide care and ultimately the overall expenses that the Medicare trust would incur as a result of the provision of services and the submission of claims. So in addition to the RBRVS cost-based reimbursement system, ultimately in 1998, the sustainable growth rate was implemented, which based on the Medicare Economic Index was implemented to serve as a cap on aggregate physician reimbursement and ultimately liabilities of the Medicare trust. The SGR formula did not limit any particular physician's payment, but instead served as an overall cap to all physician reimbursement under Medicare Part B. So again, while serving as a general check against overutilization of services, it didn't really specifically serve as a check against any one physician, in that no particular physician felt the need to limit their costs, because if you in theory could submit claims in relation to your services provided, and in some cases overutilization of services, you were still standing a reasonable chance of getting a larger payment than if you were to check your own services provided. At any rate, the SGR formula, because it did threaten to make cuts to physician payments, was never a popular program and faced repeated challenges on implementation, which was an aggravation both for physicians and for legislators. So what we had seen is that SGR had faced a number of challenges to implementation, and ultimately was never implemented as intended. SGR implementation did affect, for example, federal budget making, but was never implemented in the fashion that would have limited actual payments to physicians, because as SGR implementation was continually put off, the cuts to physician reimbursement, of course, grew larger and larger, because the cuts were intended to reflect cuts that should have been made in the past but were put off due to stopgap legislation. So at the end, when sustainable growth rate was finally repealed, the potential cut to physicians if SGR were implemented at the time of the adoption of MACRA would have been somewhere between 20 and 25%, which of course would have been a political nightmare to implement, given the strength of both the healthcare industry and the physician lobbies. So SGR was never truly implemented as intended, but even though it was not, the fact that Congress had to implement stopgap measures to put off the implementation for anywhere between several months to several years at a time continually posed a threat to the healthcare industry, because it prohibited the healthcare industry from making plans regarding the type of reimbursement that could be anticipated, with that 20 to 25% cut in payment looming should Congress ever fail to adopt a stopgap piece of legislation. So this was all resolved in April of 2015, which remarkably was one of the few cases of bipartisan legislation that was adopted under the Obama era, and serves to be perhaps, given recent congressional votes as recently as last night, maybe one of the few remaining pieces of bipartisan legislation from the Obama era. The MACRA, Medicare Access and Chip Reauthorization Act, ultimately repealed SGR payment methodology, and what it has done, instead of threatening to provide 25% payment cuts, has mapped out for the near to mid-term future a plan for gradual increases of payment and a methodology for physicians to earn bonuses and adjusted reimbursement based on their compliance with the various regulatory reporting or structural schemes under the MACRA regulations, which we'll discuss today. So briefly, there are two ways to participate under MACRA, and you'll find that these two tracks perhaps replicate the various risk versus non-risk tracks we see in other Medicare programs at this time, such as the Accountable Care Organization program, which we'll discuss and draw analogies to. The methodologies provide for one track where the physician can comply with various reporting requirements and assume less risk of downward payments or payment reductions, whereas the other track permits perhaps higher payments, but also a greater risk that the physician may receive a payment reduction if they're not complying with all requirements for the alternative payment model program. So the first track is the MIPS program, or merit-based incentive payment program, and the second, of course, is participation under an alternative payment model, such as an accountable care organization, which we'll discuss in detail. But the physician can participate in either one of these programs and receive payment based on that model. And of course, the physician has the opportunity to alternate between models as they see fit based on their participation in an alternative payment model. So we may from time to time see as deals are struck and allegiances are formed in alternative payment models, physicians may fall in and out of the APM model and in their interim participate in a MIPS reporting model. Now, one of the key elements of both models, or more specifically the MIPS model, is that it's intended to reflect both quality of care and cost reduction reporting, which I'm always careful to point out that quality of care reporting is not the same per se as providing actual quality of care. And so, to the extent that I say that a MIPS participant is one of the better participants, or is providing better care under the quality of under the MIPS program, what I really mean, by and large, is that they're able to report better under the MIPS reporting requirements, as opposed to perhaps providing better care. So there's always a distinction between those, and of course this was one of the major criticisms against the MIPS model, but for the time being, I'm not sure that anyone has a better solution as to how to ultimately reflect that the physician is providing a cost-effective and low-cost care. So the MIPS reporting model is intended to simplify the quality and cost reporting that physicians have currently been required to undergo. And I will note that the commentary at the time of adoption of MACRA really indicated that MACRA perhaps stands to be the more significant of the two. If you compare MACRA and the Affordable Care Act, MACRA may be the more significant regulatory sea change of the two pieces of legislation. I used to say simply because it reflects a greater number of healthcare providers, meaning individual physicians. Now, of course, we have to say that it also may be the remaining piece of legislation from the Obama era. So to the extent that MACRA survives and significant portions of the Affordable Care Act do not, MACRA may be the hallmark legislative change of the recent past. So I discussed the MIPS programs and the alternative payment model programs, and I will discuss in detail the various reporting programs that is intended to replace. So with that, I will say generally that that MACRA is intended to replicate an overall broader move towards a value-based or alternative payment model-based reimbursement versus fee-for-service. And you can see here that the goals set by CMS for transition to value-based payment or alternative payment model-based reimbursement for 2018 are pretty significant, with 90% of reimbursement tied to some value-based measure, or 50% of all reimbursement coming through some form of alternative payment model by 2018. That's a pretty significant challenge, but CMS has reported that they're ahead of schedule for these transitions. So I think that it should come to nobody's surprise that payment for services will, of course, be going away from fee-for-service in most regards. And programs like this, if you're not participating under MACRA, if you're for a hospital, you're already likely participating in some sort of value-based or perhaps an APM program in your own right. So with that, I will jump into the details of the MIPS track, and before we turn it over to Joseph, who will discuss the APM track. So the MIPS program is intended to reflect quality reporting by physicians of care and also reporting of cost resource utilization for the services that they provide as well. The model was intended to create a composite score based on the various factors that are reported against which physicians will be judged against one another. So ultimately, one of the deals with MACRA is that it was intended to be a zero-sum reimbursement change, meaning that some physicians will prevail under MACRA and some will see their reimbursement cut. At any rate, the MIPS program intends to take all of the various factors that are reported under the four categories of reporting and apply those to a composite score against which physicians are judged. And then those composite scores will be transformed into percentage payment increases or decreases based on their relative strength of score. So not only are physicians affected by the MIPS program, but other non-physician practitioners such as physician assistants and nurse practitioners are also affected by the MIPS program and may participate in MIPS reporting. So with the implementation of MIPS, CMS acknowledged that physicians reporting quality of care and value of services were faced with an overlap of regulatory reporting requirements simply because as time has gone on and more reporting programs have been implemented, many of them contained the same reporting requirements. And so CMS saw a significant amount of overlap in reporting under the PQRS system and, for example, the meaningful use of EHR incentive payment program. And so CMS essentially took all of the reporting requirements under these programs, combined them into one program, kept the factors that they found to be significant indicators of quality care and cost reduction, and eliminated the overlap and the quality reporting requirements that were not significant indicators of quality of care. So MIPS reporting begins this year, and payment implications will be made based on reporting this year in 2019. So although physician payment will not change until 2019, physicians should be thinking about reporting now. The minimum reporting time, as we'll discuss, is a 90-day period in 2017, although payment increases may be made for a full year of reporting. So it's to the physician or physician group's advantage to start, if they haven't started thinking about MIPS reporting at this point. The best chance at the most reimbursement will be a full year of reporting for 2017, so physicians should be involved now. So the MIPS program, as I mentioned before, permits both a regular fee schedule payment, but then also payment bonuses or penalties based on the reporting requirements. So the first element of the payment schedule under MIPS is the fee schedule payment, which, as I mentioned, is scheduled to be relatively flat through 2023. Fee schedule payments will be flat and updated at 0.5% through 2019, and no change between 2020 and 2023. And then after that, payment updates will resume for MIPS participants. I think you'll find, in any case, as this third bullet point notes, is that there will be differential payment updates for MIPS and APM participants. And if I may just generalize, I think in every case the payment updates for APM participants will be higher, simply because, as I indicated in the CMS overarching goals slide, CMS wants to motivate physicians to participate in APMs versus MIPS. So in addition to the fee schedule payments, based on the reporting requirements, physicians may get the potential to earn up to 4% increase in bonus payments, which will gradually increase over time up to 9% in 2022. With the physicians who are doing the best job of reporting quality on the quality factors will get the 4% increase, and those physicians not reporting or doing a poor job of reporting getting a no increase or a potential penalty of up to 4%. So it is incumbent upon the physician to the extent that they want to avoid payment decreases and certainly get the opportunity for additional reimbursement, to be on the game as far as being prepared to do their quality reporting now. In addition to the payment I discussed, there is an additional 6-year bonus period where the highest performing reporters under MIPS will get an additional potential for bonus. The final rule departed from the proposed rule in providing for $500 million a year in additional exceptional performance bonus payments, which we'll discuss. I will note that the exceptional performance bonus is calculated based on a performance threshold. For 2017 is 70 on the 0 to 100 composite score scale, which we'll discuss in additional detail. And anyone above the 25 percentile above the 70 score would be eligible for a portion of that $500 million a year in exceptional performance bonuses, provided that the reporting physician achieves other additional reporting requirements as well. So that's an additional incentive for physicians that was provided by the final rule. So essentially, as I indicated, that the MIPS program takes the best of the value-based program, the PQRS reporting program, and the EHR incentive program, combines them into one score, and has the reimbursement affected by the composite score that results. So you can see in the final rule there were some changes to the weights that were provided to the 4 criteria against which the score will be comprised. Clinical quality reporting, which most closely replaces the PQRS program, is very heavily weighted in early reimbursement, but is reduced as cost-based factors are added in 2020 and are increased over time. Advancing care information essentially replaces the EHR incentive program, and clinical practice improvement is a criterion that essentially reflects how well the physician is providing customer service or patient-focused services, as we'll discuss. That factor is new. It's not reflected in any other previous reporting program, although you'll see analogies to factors under the ACO program. And that 15% will go towards the overall composite score. So because, as I mentioned, it's a zero-sum game, physicians achieving a score of 100 can expect to get the full 4% payment increase on an annual basis, and physicians on the lower end of the scale can expect to see payment decreases potentially, especially in the early stages if they do not report at all. So this does put some skin in the game for physicians, and it's not simply enough to go on with your regular physician practice anymore. I think that to the extent that you want to see the same payment that you've been receiving under fee-for-service, generally, it's incumbent to be a good MIPS participant, or else you'll see potentially 4% payment reductions in the early stages. So the first criterion, clinical quality, does reflect that essentially the same criteria as under the PQRS program, and the reporting requirements were reduced under the final rule. This final bullet point indicates that it was anticipated that the physicians would be required to report on 9 criteria or quality measures. The final rule reduced that to 6, including 1 outcomes measure. Or if you are in a particular specialty that has fewer than 6 measures, all of the measures applicable to your specialty. There are some specialties like nephrology that have no measures, although nephrologists do not get the benefit of avoiding reporting. They're required to find measures that do apply to their practice and report on those. Resource utilization essentially reflects the cost of care, and what is unique about this factor is that there's no proactive reporting requirement. The composite score for resource utilization will be based on CMS's evaluation of actual claims data. So while you will get a score on your resource utilization, your score is not based on any active reporting requirement. As we discussed previously, resource utilization will not go into effect until 2020, and so for this first year, there's no payment implication to your costs. But as time goes on, resource utilization will become a more important factor to consider in going towards your overall composite score. The Advancing Care Information Program replaces the EHR incentive reporting. As with most of the other criteria under MIPS, ACI reporting was reduced as part of the final rule, and with the intention, of course, both simplifying and creating achievable goals for MIPS participants. So you can see that there are 5 base criteria and a number of additional criteria with the goal of obtaining 100 points towards your overall score that will go to the 25%. Apologies for the error in the bottom bullet point there. That will go to the 25% that go towards your overall score. So if you receive 100 points in ACI reporting, you get the full 25% of ACI towards the composite score. If you achieve less than the 100 points, then you get a percentage of that 25% towards your composite score. And finally, the MIPS program requires reporting on clinical practice improvement. The final rule reduced the measures that are required to be reported on, and essentially reflects efforts by the physician practice to achieve outreach or to provide better access to care for patients. So, for example, public health reporting is a clinical practice criterion against which you can report expansion of your practice access by providing expanded hours and things like that are reportable measures as well. By reporting on the 4 criteria or 2 very highly weighted measures, all of which are listed in Table 8 of the final rule, you can achieve your clinical practice improvement portion of the composite score. So as I mentioned, for 2017, physicians have the option, and this is a change in the final rule as well from the proposed rule, physicians can have the option of reporting on either a 90-day period or a full year of results. If reporting on the full year and if reporting on all criteria that I previously mentioned under the 4 categories, and achieving the 25th percentile above the performance score, you can also be eligible for that performance bonus, which is a portion of the $500 million. If you choose not to go that route, you can still report on the full year or 90 days if you prefer. And if you report on one quality measure or one improvement activity or more than the required EHR measures, you can be eligible for the 4% payment increase. If you report on fewer than that, only one improvement, one quality measure, or just the required EHR measures, you can avoid a payment reduction. If you report on no measures, then you may be subjected to a 4% payment reduction. So for the time being, this will not be, the payment reduction will not be implemented based on 2017 reporting, but going forward, if you fail to report at all, you'll be eligible for a 4% pay cut. And I accidentally scrolled to the end, so I apologize there. I will just add one thing. There are a number of ways that you can report under MIPS. Most of them replicate existing reporting options, including through your EHR system and through your existing PQRS reporting system. There's also a CMS web interface for reporting. So with that, I will turn it over to Joseph, who will address the APM alternative to the MIPS program and the reimbursement implications under the APM model.
Well, thank you, Mark, for that excellent overview of pre-MACRA background in MIPS. My name is Joseph Keillor, an associate in the St. Louis office, and I'll be sharing an overview regarding a competing incentive scheme under MACRA, which is the Advanced Alternative Payment Model, or Advanced APM Incentive. At the highest level, Advanced APMs are a way to be excluded from MIPS reporting and receive a distinct set of incentives if you are participating in a MACRA-favored payment model that is sufficiently risk-based and satisfies certain other criteria that we'll explore further in a moment. Like MIPS, this prong of MACRA is likewise consistent with CMS's objectives over the past several years of moving the healthcare system from volume-based care to value-based care, and CMS underscores this repeatedly in the commentary. While additional slides will discuss exactly how to become a qualifying APM participant, or QP, the financial impact of achieving that status is relatively straightforward. For years 2019 through 2014, qualifying APM participants, QPs, receive a lump sum incentive payment of 5% of the prior year's Part B covered professional services. But notably, each payment year is tied to a QP performance year 2 years prior. So for example, advanced APM participation in 2017 dictates whether one is a QP for the 2019 payment year. Further, beginning in 2026, QPs receive a higher physician fee schedule update as opposed to MIPS counterparts. And finally, QPs are excluded from MIPS penalties and bonuses. So while some harsh commenters wanted these payments to be contingent on the clinician performing well under their particular advanced APM in terms of savings or quality, CMS was very clear in the rule and commentary that as long as your participation in the advanced APM hasn't been terminated, the clinician doesn't need to be, say, an above-average performer in terms of quality or efficiency within their particular advanced APM. And similarly, the particular advanced APM with which the clinician is associated, so let's say ACME ACO, it doesn't need to be an above-average performer in terms of quality or efficiency as compared to other ACOs. So this agnosticism by CMS with respect to performance contrasts with participation thresholds, which we'll discuss in a few slides. So regarding these incentive payments, payment is made to the eligible clinician's TIN that is affiliated with the advanced APM entity through which the eligible clinician was determined to be a QP. But notably, if the physician has changed practices, the payment follows the clinician to the new 10. The most fundamental prerequisite in becoming a QP that receives an advanced APM incentive is to be linked up with an advanced APM. So there were three core statutory requirements regarding the advanced modifier to alternative payment model. So the first requirement related to certified EHR technology. The final rule states that an advanced APM must require at least 50% of eligible clinicians to use certified EHR technology, or each hospital if hospitals are the primary APM participants. While the proposed rule would have increased the threshold to 75% beginning in the 2018 performance year, the final rule yielded to objections by commenters and did not adopt that approach. Additionally, CMS displayed remarkable flexibility on this element for Medicare Shared Savings Program, Track 2 and 3 ACOs, glomming onto a single quality measure that assesses meaningful use of EHR technology. Because that single quality measure has a slight impact on an ACO's shared savings or loss calculations, CMS essentially said, that's good enough. We're going to construe that measure as effectively requiring a majority of the clinicians to use certified EHR technology. So CMS likewise displayed significant flexibility regarding the second core statutory requirement, which was that an advanced APM must provide for payment based on quality measures comparable to those in MIPS. In the final rule commentary, CMS indicated, we believe that quality measures that are endorsed by the National Quality Forum would meet these criteria, but additionally, measures not QF endorsed can potentially satisfy this requirement as well, as long as they have an evidence-based focus and are reliable and valid. Further, not all quality measures under which an advanced APM is assessed are required to be comparable, and not all payments under the advanced APM must be based on comparable measures. So you can see the theme here running through these first two elements is how hard CMS was working to try to have significant number of models and meet the advanced APM criteria. So through the rulemaking process, CMS has also begun to flesh out the more than nominal risk standard, subject to increases in future years. So as you can see, for 2017 and 2018, CMS wants to see 8% of Part A and B revenues be at risk by the APM entity, or 3% of the expenditures for which the entity is responsible be at risk on a benchmark basis. So those percentages will likely increase for performance years beginning in 2019, as CMS is considering a 15% revenue-based standard. And CMS is also exploring layering in further subtleties to the calculations, such as possibly taking into account revenues of parents, subsidiaries, etc. Additionally, there is a different sliding scale for medical home model advanced APMs, specifically 2.5% of estimated average Part A and B revenues in 2017, which slowly increases to 5% in 2020. So finally, CMS scrutinizes every track or option within an APM in assessing whether it meets the advanced APM standards. For example, there are 3 Medicare Shared Savings Program tracks, so CMS examined each track separately. CMS recently published via its website the final list of advanced APMs for the 2017 performance year, which is reflected on this slide. Notably, CPC Plus qualified through meeting the specific standards applicable for medical home model APMs. Additionally, the CJR model was tweaked a bit so that it would satisfy the criteria and could become an advanced APM. So some models are entirely voluntary, like the MSSP Track 2 and Track 3 models, whereas the CJR model encompasses about 800 participant hospitals required to participate via regulation based on their geographic location in specified MSAs. So notably, you don't see MSSP Track 1 ACOs on this list, as they are not subject to downside shared losses. So while CMS resoundingly rejected the suggestion of some commenters to creatively and liberally interpret the statute to deem MSSP Track 1 ACOs to somehow be engaged in sufficient risk so as to qualify as an advanced APM, CMS did respond to comments that had expressed concern about relatively limited advanced APM options in 2017 by foreshadowing a Track 1 Plus ACO for as early as the 2018 performance year. And this may be a relatively important further MACRA development to keep an eye on this year to see kind of the details of how that model fleshes out. Additionally, in the MACRA rule, CMS repeatedly foreshadows other expanded advanced APM options in future years, really emphasizing that it went out of its way to try to establish the criteria in a way that would allow for flexibility so that it could come behind that and in the future continue to create innovative advanced APM models and options. So now that CMS has stated the advanced APM criteria in the final rule, it doesn't plan on holding a public comment process for what it views as just an administrative task of each individual assessment of whether a particular model meets the advanced APM criteria. It will just continue to determine that on its own, publish those to its website on a rolling and no less than annual basis, and also note that determination in program-specific materials like a request for application as it rolls out and introduces a new payment model. So let's now turn to probably the most complex and pivotal aspect of the advanced APM incentive. Critically, it's not enough for a clinician to formally participate in an advanced APM, but rather the clinician's APM entity needs to exceed designated participation levels. So essentially, CMS will conduct calculations regarding the first 8 months of a performance year and calculate threshold scores for all eligible clinicians as a whole that are identified as part of an advanced APM entity. So the basic calculation is Part B payments for services to attributed beneficiaries divided by Part B payments for services to attribution-eligible beneficiaries for the payment amount threshold. Similarly, for the alternative patient count threshold, the basic calculation is attributed beneficiaries divided by attribution-eligible beneficiaries to which services were furnished. So, to take ACME MSSP ACO, for example, it could run into problems if it has a distinctively large proportion of its patients that are flighty or disloyal in that they receive the majority of their primary care services outside the ACO, as ACO attribution is based on primary care services. So notably, there are 2 exceptions to conducting these calculations at the advanced APM entity level, in which case the calculations are made at the NPI level. So the primary exception is when an eligible clinician participates in multiple advanced APMs and none of them meet the QP threshold as a group. Additionally, there's a second exception that primarily applies to certain episode payment models that use affiliated practitioner lists rather than participation lists. To briefly revisit the timing piece of all this in more detail, following the proposed rule, CMS was severely criticized for an kind of fairly obvious chicken and egg problem in that parties wouldn't know for sure whether they would become QPs who are eligible for the advanced APM incentive and would need to hedge against that in assessing potential MIPS participation. CMS partially mitigated these concerns by promising to provide hypothetical threshold scores early in the performance year and also decided to make QP determinations based on achieving any of 3 cumulative snapshot periods. So the snapshot periods are based on January through March claims, January to June claims, or January to August claims, with it taking CMS about 4 months after each respective period to allow for claims run out and accomplish its calculations. So threshold achievement only needs to occur in at least one of the 3 snapshots, and once achieved, QP status can only be rescinded by either the advanced APM entity's participation ending prior to the end of the performance year, or in the event of program integrity violations. So looking at this summary chart of the threshold levels, the rule-based patient count thresholds are lower than the statutory payment amount thresholds, indicating that CMS is attempting to make these thresholds more attainable for clinicians. I'd still ask, whether these thresholds are so robust, particularly in the later years. As the final rule commentary rather offhandedly noted that typically only about 30 to 50% of an advanced APM entity's total population of beneficiaries for whom its eligible clinicians furnish services are actually attributed to the advanced APM entity for a performance period. So this seems somewhat surprising that although CMS was trying hard to come up with a long list of advanced APMs, it seems to be fairly aggressively challenging APM entities to figure out ways to establish patient loyalty and continuity of care, notwithstanding beneficiary freedom of choice. So, and beginning with the 2021 payment year or 2019 performance year, if a party cannot achieve a threshold based on Medicare data, the party can alternatively achieve the threshold through an all-payer-based calculation and a reduced corresponding Medicare threshold. While the MACRA final rule spends a couple dozen pages discussing these all-payer totals that take into account, other payer advanced APMs, significant elements of this concept are deferred to future rulemaking, including a key prong of the more than nominal amount of risk standard, and also details of submissions to CMS regarding what in many cases here would be private payer data that would be affecting these calculations. So as foreshadowed by the preceding slide, when parties do not achieve a QP threshold, not all is lost as there's still some benefit to achieving the lower partial QP threshold. So while partial QPs don't receive advanced APM incentives, they are exempt from MIPS reporting and potential penalties, although if optimistic about their ability to do well under MIPS and receive the upside MIPS incentives, parties may elect to participate in MIPS. And with that, I will turn it over to Bernie.
Thank you, Joseph. Good afternoon, and thank you, Mark. I'm Bernie Duco. I'm in the Houston office of Norton Rose Fulbright, and I'm going to spend a few minutes talking about the, I guess what I would consider on the macro level, the, if I can get a change on the slide. Start on a macro level, some of the integration implications of MACRA for physicians. And as let me try one. Okay. Forgive me.
Use the page up and page down keys.
I'm hitting page down.
Just Q and I'll click Bernie.
Okay, next page. Okay, I'll keep talking. As has been noted a couple of times, MACRA embodies the fundamental goal of CMS to shift Medicare reimbursement from fee-for-service to performance-based. And I think as you've seen, I think for physician reimbursement, I think fee-for-service is probably now a misnomer, and really it is more defined by its performance-based elements. And I think as CMS will continue to push into basically a risk and performance-based elements of reimbursement. And in MACRA, through MIPS and advanced APM, has created significant incentives for physicians to align with health systems, large clinics, or well-capitalized MSO organizations. Some commentators said this may be the leading change in Medicare reimbursement as far as encouraging greater physician integration with hospitals or other large organizations. And the reason is this alignment is essential because only through it can physicians reasonably gain access to the clinical and financial structures necessary to report, perform, and you would hope thrive under MIPS or advanced APM requirements. I think there's a couple of points to be drawn out of there. First, while there is a fair amount of time and effort spent in MACRA as far as allowing physicians to ease into the program, that easing in comes at a cost, meaning that you may ease in, but you're going to see less reimbursement into the future in most cases. In addition, I think a significant change under MACRA as compared to some of the current and reporting systems that have been around is now the physician's goal should no longer get to be the minimum necessary to meet the reporting requirement, because what's now necessary to thrive under either MIPS or under an advanced APM is a strong, robust clinical system with regard to performance and reporting, and then with regard to the APMs, actually have a financial structure in which the physician can deal with risk in an effective manner. I also wanted to point out that there's nothing in MACRA that requires alignment with hospitals. As you know, to my earlier point, is that the physicians have incentive to align with health systems, large clinics, or well-capitalized MSO organizations. What the drive is to align with organizations that have these clinical and financial systems that allow the physicians to thrive under MACRA, under either MIPS or the APM. That's really the heart of it. And whether those systems are held or can be capitalized by a hospital, a large clinic, or even an MSO organization is really neither here nor there. It's going to be decided by a lot of factors dealing with market availability and other factors. I want to move now to the potential physician alignment models, and I'm sure there'll be several variations on these, but I think there are four main ones that you could list, and that would be employment, leased or contracted services, MSO, or ACO or CIN membership. And what we're talking about there is what is the basis under which, what is the form of alignment that the physician is going to use to get access to these clinical and financial systems I've mentioned. I think of the ones I've mentioned, you can divide them into two different types at a basic level, and I think this is important when we talk for a little bit about some of the regulatory concerns. I think with regard to employment and lease or contracted services, the commonality there is that the physician is moving into an organization that has the clinical and financial structures available, presumably to thrive under MACRA. Under MSO and the ACO or CIN, it is the MSO and the ACO would actually be providing those services to the physician's current practice entity, which would continue to be the billing entity. So it's a different view towards things. And again, there's a lot of other factors that go into play as to whether or not a physician would want to maintain his or her current practice organization or move into another one. The alignment model that's selected will raise issues about the extent of support provided and the financial terms under which that support is provided. And what I mean is that the commentary in MACRA makes clear that MACRA does not change the underlying arrangement with the physicians. So there is no equivalent of the MSSP waivers that MACRA creates. So when you're looking at the integration, the alignment that physicians may pursue, you need to look at the nature of that financial arrangement that's being created to achieve that integration. And depending on which financial arrangement is chosen is going to change the statutory analysis, the regulatory analysis with regard to the terms under which that can that support we've been talking about can be provided. So, for example, if an employment model is used, I think it's straightforward, and I think the regulatory issues are really fairly minimal. The physician's employer can have a very effective, robust clinical and financial system, and I don't think the fact that the physician has the benefit of that as employee really raises a lot of issues. Contrast that, say, however, with regard to an MSO, where an organization is providing these services to a physician's practice entity. Under that arrangement, it seems to me that the value and what's being paid for the value of those services being provided is going to receive high scrutiny and will have to be carefully looked at in structuring what that arrangement is. Under the if you have an MSSP ACO, there you have the possibility of looking at the waivers as a way of addressing some concerns that might otherwise exist about providing these types of this type of support to physicians so that they can thrive under MACRA. Let me turn next to the MACRA implications for ACO and CIN development. As I mentioned, there's nothing that's required that it be that physicians align with hospitals, but it seems that the ACO and CINs that have been developed by hospitals are a leading candidate for the type of organization that physicians might consider aligning with. And for MACRA, for ACOs and CINs who have had difficulty in recruiting physicians, I think it could be considered a windfall. And that is that MACRA, the financial benefit that physicians can derive by becoming a participant in a CIN or ACO under MACRA is a significant additional element to reasons why to join an ACO or CIN. If you look at the current potential financial advantages for joining, you've got, well, you might get a share in a MSSP savings award if, in fact, it's an MSSP program. A physician might share in improved private payer contracting. That's oftentimes slow to develop. And finally, the physician could participate in various health system-sponsored programs that provide compensation to ACO members. Again, that will depend on the engagement of the health system. But MACRAs and being able to participate in that, the physician should at least, it seems, see that either as the potential for having a significant benefit through improved performance over MACRAs, or at least a way of avoiding a penalty for poor performance under MACRAs. Finally, I'm going to turn to the MACRA implications for health systems. And this is, I draw an analogy to the MSSP ACO program. And like success under an MSSP program, success under MACRA is going to reflect itself in the form of higher reimbursement to physicians. Well, where's that higher reimbursement going to come from? Where it's going to come from will be likely at the cost of fee-for-service inpatient revenue that would have been accrued to the health system involved. So as health systems, I don't think health systems really have a choice as to not exploring this, because it's far better to have be aligned with a MACRA, with a MACRA organization than to have one that's completely independent of the hospitals. But these MACRA-based organizations, or that provide these MACRA services, will have to be managed and carefully developed as they move forward, and as part of the health system's overall move from a fee-for-service basis to a more performance and eventually risk-based performance financial model. And I have concluded my remarks with that, and I think we have run out of time so we won't be able to answer questions. However, we do have a few, and we will answer those via email. Let's see. So for those lawyers requesting New York CLE credit for this presentation, please make a note of the following number, 101-27102. I'll repeat that, 101-27102. You will be asked to repeat this number on an online evaluation regarding the program, which Norton Rose Fulbright will email to you. Thank you for joining us. This completes today's program. Thank you.